So a few words about CT angiography in post-CABG patients. So why CT after CABG? We all know it's a non-invasive technique for the evaluation of graft patency. It's an alternative to catheter angiography. So not just we look at the graft patency, but also we can evaluate the native coronary arteries as well as the sternum and the mediastinum at the same go. So what are the indications? Usually when patients present with chest pain, for the evaluation of such patients in post-CABG patients, we do this. Immediate post-op complications, and for when redo surgery is planned, CT angiography can be planned for such patients. So what is that a surgeon wants to know? We get to know the number of grafts, the entire course, the origin, the course, and the anatomical site of the graft patency, any stenosis there, the native vessel disease, as well as post-op complications, and if any retrosternal grafts which is adherent to the sternum is also evaluated. So what do we look at? These are some of the CT images showing, this is a Lima graft that we're seeing arising from the subclavian artery. The entire course is seen. And also the anastomotic site, and also the runoff vessel. The entire extent of the graft vessel is seen. This is the second example where we're seeing an occluded graft. We're not seeing anything beyond the stump. So this is an occluded graft. The third example, this is an SVG to RI graft where we're seeing focal significant stenosis there. This is a VR image showing all the grafts in one image, which acts like a roadmap for the treating physician. These are a few examples. This is a scanogram of a CT angiography where we see the sternal wires. We look at the patency of each and every sternal wire, any breakage in that. As here we can see there's a sternal wire breakage here. The same thing on an axial CT scan, there's a break that we're seeing very well imaged. This is immediate post-op. This is a bit of edema that we're seeing in the mediastinum, which is taken as normal in immediate post-op, and there's some amount of pleural effusion that is also considered normal. We always have to see the sternum, which has to be approximated with one another. If we see any gap, it is termed as dehiscence. So it is very well appreciated on a CT, both on coronal and axial images. So these are a few examples where we're seeing a Lima graft, which is anastomosed to the LAD. The entire extent is seen. The anastomotic site is very well imaged. The distal runoff vessel is also seen. The same thing we're seeing on a VR image. This is a Lima LAD graft. This is an SVG to OM graft. Sometimes a sequential graft is placed where a single graft is anastomosed with two native coronary arteries. In this case, there's OM1 and OM2. Both are anastomosed with a SVG graft. Then other examples where both Rima and Lima are used. Rima is anastomosed with the LAD and the Lima to the OM. So what are the complications that we can pick up on a CT? The graft occlusion, as we saw in previous images. The pseudoaneurysm at the site of anastomosis can be picked up. A perigraft hematoma can be picked up. A sternal wound infection, where this can be missed in conventional angio. This can simultaneously be picked up. Any mediastinitis, any retrosternal collection can be picked up. Pericardial effusions, and any Lima graft that is adherent to the sternum can also be imaged. So why do we do a CT before we redo CABG? So as I already discussed, it maps the entire extent of the graft. It also detects external dehiscence, adhesion, pseudoaneurysm, everything in one go. Let's discuss few cases. This is a 65-year-old male patient, status post CABG. 3 years ago, 3 grafts were placed, now presented with chest pain. As we can see, these are VR images showing a Lima LAD graft, which is patent. There's another OM graft, which is patent, SVG to OM. But we are not seeing the SVG to RCA graft, just a nib is seen. So this is occluded. This is a cause for his chest pain. Another case, a 70-year-old gentleman, status post CABG 7 years ago, 4 grafts were placed, now presented with chest pain. On echo, there was regional wall motion abnormality with moderate LV dysfunction. As we can see, the Lima to LAD graft vessel looks hairline very thin in caliber, and the distal graft vessel is not at all seen, which suggests a near total occlusion. The same thing is appreciated on a VR image. It's hardly seen. The Lima LAD graft is very thin in caliber, And also the SVG RCA graft beyond the osteoproximal segment is not seen. So we have two occluded grafts here, which needs a redo surgery. Another case, 75-year-old gentleman, status post CABG 8 years ago, and there was a PTCA done, SVG to RCA graft 2 years ago, now presented with breathlessness. As we can see, there's a long stent that was placed, SVG to RCA graft, and we can very well appreciate the instant stenosis there, significant stenosis, which was a cause for his breathlessness. There's another case, 70-year-old gentleman, status post CABG 8 years ago, presented with chest pain and SOB for 2 weeks. ECG was normal with mildly elevated troponins. CT was asked for to know the cause for the chest pain. Here we are seeing a saccular contrast-filled outpouching that is arising from the SVG graft. This was a case of pseudoaneurysm from the graft that we could easily pick up on CT. Another case, 67-year-old gentleman, status post CABG, performed 6 weeks after the CABG, presented with fever and sternal pain. There was a purulent discharge oozing from the sternal incision site. Lab parameters showed elevated CRP and leukocytosis. On CT was asked for, we can appreciate the sternum. There's lucencies in the sternum that we're seeing. There's dehiscence. There's wide gaping between the two sternal. There was a lot of air pockets between that. There's some amount of fluid there in the retrosternal area. So this was a diagnosis of sternal osteomyelitis was done. Similar case, there is lytic areas in the sternum with similar history. Retrosternal collection, sternal dehiscence. A sinogram was done from the sternal wound. The contrast was injected. We could see a linear contrast-filled sinus tract that was extending from the sternum to the anterior margin of the, up to the skin to the anterior margin of the sternum. So this was also a case of sternal osteomyelitis. So the key takeaway points are, with CT, we can highlight the graft occlusions. Then we can also comment on the native coronaries as well. We can see any retrosternal, any vessels that are passing, which can be a red flag for the surgeon in case they're planning for a redo surgeries. So in just radiology input prevents intra-op surprises. Thank you.